to our panel discussion on the evolving landscape of lung cancer treatment. We know combining PD-L1 inhibitor with other drugs could be a game changer in treating lung cancer. By teaming them up, doctors aim to make the immune system stronger against cancer. Understanding how these combos work might lead to even more effective treatments for lung cancer. Our topic for today is Beyond Monotherapy, exploring combination strategies with PD-L1 inhibitor for enhanced therapeutic efficacy in lung cancer. Our speakers for the panel are Dr. Rushabh Kothari, Director, Oncoin Cancer Center. Dr. Kothari specializes in medical oncology with DM from Tata Memorial Hospital, Mumbai. Lung cancer is a key area of his focus. Dr. Aparna Sreevatsa, Consultant Medical Oncologist, Narayana Multi-Speciality Hospital, Shimoga. She has special interest in breast cancer and lung cancer. She has completed DM Medical Oncology from Kidwai Cancer Center, Bangalore, and has been practicing in Shimoga for the last 7 years. She's authored a book, Cancer Ji Answer, in Kannada, which is getting translated to English, Hindi, Tamil, and French. A very warm welcome to our panelists. So my first question is to Dr. Rushabh Kothari. So what is immunotherapy and what are the different types of immunotherapy for cancer?
So traditionally, what we used to give in systemic treatment was called as chemotherapy. It generally used to work on cancer cells and normal cells. Targeting both, and we used to have cycles of say 7 days or 21 days. So generally by 21 days normal cells were able to recover while cancer cells were not able to recover, and sequentially there was kill of cancer cells. But because of this effect on normal cells, there was significant toxicity. So in immunotherapy, it is generally an injectable drug which goes into your body and it changes immune environment, where it modifies T cells such that T cells would act on cancer cells. So the toxicity profile is quite different, and it is in absolute number, it is lesser than what we see with chemotherapy. So tolerance with immunotherapy is better, side effect profile wise it is better, and it's efficacious in significant number of cancers, and in not only in metastatic setting, now we are seeing it being used in curative setting also. So the mechanism of action is completely different than what we see with chemotherapy or even with targeted therapy. Largely, the scientifically proven immunotherapies generally which we use or for which we use immunotherapy word currently is either it is checkpoint inhibitors which are used largely in solid tumors, which is in form of PD-1 or PD-L1 blockade or anti-CTLA4 blockade. The drug names which are available in India would be nivolumab, atezolizumab, pembrolizumab, ipilimumab, and durvalumab. So these are the drugs which are available at present in our country. And for liquid tumors, generally we would refer it to CAR T cell therapy.
Right.
So which is again a kind of immunotherapy and helps as of now in liquid tumors.
Right. So thank you for the brief introduction about immunotherapy. So Dr. Aparna, how have immune-based combination therapies revolutionized the first-line treatment for advanced non-small cell lung carcinoma?
Yes, so as Dr. Rushabh has already given us an introduction about immunotherapy. So as he said that initially we were using chemotherapy for most of our patients, especially when they are in stage 4. There was no other treatment other than chemotherapy. But chemotherapy is a bomb, so it comes with lot of side effects. So then came the immunotherapy, and when we started using immunotherapy, we saw that not all patients were responding that great to immunotherapy, though it boosts the immune response of the patient. It actually boosts the immunity of the patient. But still, many patients weren't getting that good response that we were looking forward to. So then came the concept of combination strategies. So there are different combination therapies. So see, when we go to a war, we don't bank on a single weapon, right? We have an armamentarium of different weapons. So we have three important weapons for lung cancer. One is chemotherapy, the other is immunotherapy, and the third one is targeted therapy. So today we are not banking on one particular treatment. We are combining different options. So let's see. So let's understand how we decide for a particular patient. A patient comes to me with lung cancer. So how do I decide what should be the treatment for this one? So we haven't completely understood the entire game of this lung cancer, but still we have an important marker that is called PDL1. So this PDL1 to some extent tells us whether the patient responds to immunotherapy or not. So it is a simple test which is done on the lung cancer, the tumor, and it tells us as a percentage. So if it is more than 50%, if the PDL1 is more than 50%, there are high chances that the immunotherapy will work well. So for such patients, we give single agent immunotherapy, just immunotherapy alone.
Right.
So suppose the PDL1 percentage is less than 50%. Then it says that immunotherapy alone won't give us good results. So we combine the immunotherapy with chemotherapy. So, and also in some patients who have PDL1 of more than 50%, immunotherapy takes time to act. So what happens is I tell the patients also, see, immunotherapy is like switching on the tube light. If you switch it on today, the light will come on after 2 months. So see, the immunotherapy, it has to boost the patient's immunity. His own cells have to go and attack the tumor. Then the tumor has to shrink. So this whole drama will take at least 2 months. So we should have that kind of time. So is that patient fit enough? Do we have that kind of time for the immune response to happen? Sometimes the tumor is bulky. It is compressing on the windpipe. The patient is having difficulty in breathing. So we want rapid tumor shrinkage. So we want a bomb. So even if PDL1 is high, if the tumor burden is high, and if patient is symptomatic, even in such patients, we combine immunotherapy with chemotherapy. And so we have discussed two combination strategies. One is immunotherapy with chemotherapy. And the other one is you combine immunotherapy with another immunotherapy. So dual immunotherapy agents. So that is a strategy we use to combat the resistance. So I told you that immunotherapy doesn't work in all the patients. Some people are inherently resistant to immunotherapy. That is called primary resistance. And sometimes they respond for some time, some 6 months, the tumor shrinks. And after that time, the tumor starts to grow again. So that is called secondary resistance. So to combat this resistance, we use two immunotherapeutic agents with different mechanism of action. So typically we use nivolumab and ipilimumab. So this combination helps to prevent the resistance in patients. And the third option is immunotherapy, chemotherapy, and targeted therapy. We bombard the patient with all that we have, all the three. So we have atezolizumab with chemotherapy with bevacizumab. So it combines an anti-angiogenic agent, a targeted therapy, which will decrease the tumor blood supply so that the tumor starts to shrink. So today we have multiple options, and for every particular patient, we pick and choose what is the best thing for this patient. And so with all these maneuvers, we are able to increase the survival of the patient. So today the lung cancer patient is surviving longer and with a very good quality of life, and sometimes even without chemotherapy also, they are taking treatment and surviving longer.
Oh, that's great. So Dr. Rushabh, which PDL inhibitors are approved as first-line treatment for advanced non-small cell lung cancer? You have named few, but specifically for lung cancers.
As Dr. Aparna told, for first line treatment, we have pembrolizumab alone, pembrolizumab with chemotherapy, both approved. Again, we have ABCP, so atezolizumab with bevacizumab with chemotherapy. Atezolizumab alone, when given in high PDL1. Again, both these are approved indications. Similarly, we have second line approvals for all three of them: nivolumab, pembrolizumab, and atezolizumab. So again, based on adeno and squamous, the chemo counterpart changes with this immunotherapy, but largely pembrolizumab and atezolizumab have been approved for first line, and in a subset of patient, nivolumab plus ipilimumab is approved for first.
Right. So Dr. Aparna, so there is always a tumor heterogeneity. We know that cancer is always evolving. So how does tumor heterogeneity affect the use of PD-L1 inhibitor in treatment algorithms? And how do you face it? How do you address it? Dr. Aparna.
So,
Yeah.
yeah. So this tumor heterogeneity is a big headache for us, but as per the guidelines today, we don't use intratumor heterogeneity to choose a treatment. So as you said, cancer is a dynamic process, and there is always a stress on the cancer to evolve. The moment we start treatment, the cancer, it changes its colors and it tries to escape whatever mechanism we are using. So this, what is this tumor heterogeneity? So it is like, so all the cancer cells are not similar. So so just for understanding, it is not monomorphic. So it's not like, suppose you consider a school children, they are all in the same uniform. They are all similar. But just think about the college. College children are all different. They're all totally different. So this tumor heterogeneity, it comes up because there is genomic instability. So the genome of the cancer is inherently unstable. It is going on having a lot of mutations. So it is seen in patients that the more the tumor heterogeneity, the worse is the prognosis. Because the moment we tackle one mechanism, another mechanism comes up. So in different the studies, they have seen that higher the intratumor heterogeneity, the worse is the prognosis. But right now in today's algorithm, we don't, and to check for the intratumor heterogeneity also, we don't have standardized lab tests. And for that matter, we say that tumor mutation burden is also an important marker to decide on the treatment, but we don't do it every day. Other than the research projects and trials where we use such metrics to decide things. Today, we are not using intratumor heterogeneity, but as the technology evolves and the tests become easily available, standardized, and we have data as to what treatment works well, we have to wait for that time for the data to mature and understand this whole process. But till that time, I think we use this normal metrics like PDL1. We check for driver mutations and see if targeted therapy can be used. And if patients do become resistant to immunotherapy, we try to use other agents which we hadn't used earlier to tackle the resistance.
Okay, that's very informative and futuristic too. So, Dr. Rushabh, how are clinicians addressing the mechanism of resistance to PD-L1 inhibitors?
As Dr. Aparna told, that is something which we are not absolutely clear of.
Right.
So, and this is the very reason why we have started combining the things. Right. Initially, when we were giving single agent immunotherapy, in any line, so in first line, also in most of the diseases, and even in lung, even if PDL1 is high, more than 50%, we will lose 25 to 30% of the patient in first 3 months. And we don't know why. So that is the very reason why we have started using combination. So most of the time it is immunotherapy plus chemotherapy in lung cancer. And in routine practice, even if PDL1 is high and if patient is fit, we would generally tend to use immuno with chemotherapy, not to take that 30% charge because we don't know when that will happen. Saying that in research and in laboratory, people are trying hard to see what is the reason for this resistance. So some proposed mechanisms are like there is changes in tumor microenvironment. There are some adaptive responses to immune cells when PDL1, which was expressed, is now not getting expressed. So these two are mechanisms which are being postulated as reason for resistance to this treatment. And there are some molecular alterations which are also postulated to be causing resistance to immunotherapy. So I think till we know the mechanism well, at least in first line, it is always prudent to use combination compared to single agent immunotherapy.
Right. So, Dr. Aparna, how might future developments in immunotherapy impact the treatment landscape for cancer patients in general?
So when it comes to immunotherapy and cancer, we are just taking baby steps, and we know that the future is brighter than what it appears today. So for last 30 years, chemotherapy has been an important game changer when it comes to cancer, but it is predicted that in the years to come, we will be using lesser and lesser chemotherapeutic agents and more immunotherapy agents. And one good thing about immunotherapy is that today in India, the immunotherapy is available, and usually patient can afford it with lot of patient assistance from the pharmaceuticals. So earlier what used to happen was we used to read in books that, oh wow, this molecule is very great, and we couldn't use it because it wouldn't be available in India. But I think the landscape is changing, and immunotherapy is coming up in a very big way, and it is affordable, accessible to our patients. And as Dr. Rushabh said, that CAR T cells are another important weapon in our armamentarium. So today, right now, CAR T cells are more useful for like the CAR T cells that we have in India are mainly for lymphomas and leukemias, but even for solid tumors, we are expecting CAR T cells to change the landscape. And with the help of technology, a lot of indigenous CAR T cells are being produced and being tested in India. So I think the future is bright, and we don't know how it will revolutionize. Definitely, it will be good for our patients, and it is good for the doctors also, that today our tone of telling prognosis to a patient is totally different from what it was 5 years back, and we are very optimistic, very hopeful, and the patient, and we are seeing sometimes we see the trial results. Oh wow, 4 years, 5 years survival, and it wouldn't happen in the real practice. But today we are actually seeing patients doing very well with immunotherapy combinations. So I think the future is bright, and we are expecting a lot of good improvement, positive improvement in the immunotherapy arena in lung cancer.
Yeah. So with this, I would like to have concluding remarks on one question from both of you. So first, Dr. Rishabh. So how does increasing awareness and highlighting the importance of immunotherapy contribute to improving patient outcomes and transforming cancer treatment?
So now patient being aware and doctor being aware, I don't think either of it is an issue now. Most of the patients are aware of it, or at least they have heard of immunotherapy. Rather, some patients are not saying that responsibility to make them aware of right choice in right patient. It is not for everyone, and it is obviously there for someone. So both these messages have to be conveyed to them. And again, I would highlight two important points as Dr. Aparna has discussed regarding accessibility. So one was patient assistance program, which he has already said on that the access has improved. The second is innovation of low-dose immunotherapy, especially in head and neck cancer. The access is tremendously improved because with low-dose immunotherapy, something which was not feasible for majority of the patient, now they have access to it. I see, like in my practice, I can see at least 70-75% of the patients taking low dose and not full dose because they can't afford the full dose still with all the patient assistance program. And the second important point which I would like to highlight would be because nivolumab, pembrolizumab, all these drugs are about to get, their patent are about to get over. There are multiple biosimilar trials available for our patients to get enrolled in. So these two ways they can have better access to this drug. PEP obviously is there, and that is most important thing. But these 2 points are also important, which again is our responsibility to let our patients know.
Right. And Dr. Aparna, your remarks.
So there are two kinds of fears that I see in patients. Number one is stage 4 cancer, any cancer. The moment they see that it is stage 4, they lose hope. So the today's world is totally different from what it was maybe 30 years ago. So even stage 4 cancers have very good treatment. Sometimes if they have mutation, driver mutation positive, they are just on some tablets for 3 years, 4 years. So patients shouldn't get disheartened that it is stage 4, and they should always be optimistic. You consult the right sort of people, consult an oncologist and take advice. So the second thing is they're afraid of chemotherapy. So patients come and ask me, you give me anything, but I don't want chemotherapy. So you shouldn't have that fear of chemotherapy. Sometimes chemotherapy can give very good results, and the side effects are not as bad as it used to be 20 years back. So there are a lot of medications available to prevent many of the side effects like vomiting, hair fall, the fever, immunosuppression. So a lot of medications are available which have made the chemotherapy more patient friendly. So you shouldn't fear stage 4 cancer or chemotherapy. And if you don't want chemotherapy, immunotherapy is already there. So don't be afraid of cancer or its treatment. Always be positive, hopeful, and take treatment and face the cancer war courageously.
Right. So with this, we conclude our today's session. Thank you so much for important information both of you have given us. Thank you. Thanks for joining.